This is GIT 8 concerning peritoneum and retroperitoneal structures. This slide is showing a soft tissue mass with the long axis and configuration of the spleen. It's called wandering spleen. And this one is showing the liver on the left and the spleen on the right, and this is due to what we call polysplenia syndrome or situs inversus totalis. And of course expect in such cases that the heart is rotated. Here the pelvis can also show some changes due to abscess formation or masses in the pelvis. Of course here there is no invasion or no infiltration, it's only submucosal edema because of the homogeneous thickening of the mucosa. The mucosa are thickened in a homogeneous pattern. There is no definite irregularity but only indentation, and here the rectosigmoid is indented. This is something benign is there, and it's not malignant infiltration or invasion, and it proved to be an abscess. A lesser sac abscess, as we said, as we examined an abscess in the pelvis, we can examine an abscess in the upper abdomen. Lesser sac abscess is an abscess behind the stomach, above and behind. So if this is the colon and this is the stomach and this is the transverse colon, it is this area which can show the abscess with fluid levels. Here are multiple fluid levels. This part of the stomach and this is part of the colon, and this is the abscess, and here the abscess is filled with contrast due to perforation or leakage. These are typical for lesser sac abscesses, usually post-operative. Now this is another abscess in which we have the esophagus. The esophagus appears dilated. This area is somewhat connected. The esophagus connected with jejunum, so this is esophagojejunostomy, and there is no stomach. So long there is esophagojejunostomy, the stomach is removed. So what is this? This is leakage into a left subdiaphragmatic abscess. Here we have the typical appearance of retained towels and sponges in the abdomen post-operative. So we can consider this group, the lesser sac abscess, the left diaphragmatic abscess, and the retained bowel as complications of post-operative abdomen, as post-operative abdominal complications. Now here we have the other way around, that the intestine are there but they are invaded subserosally. The subserosa is invaded, so we have these indentations, abnormal indentations of irregular pattern scattered along the small intestinal loops. These are due to seedling from tumors, and seedling from tumors in the small intestine are usually from the either stomach or ovary or pancreas. So the stomach, the ovaries, and the pancreas are the main common causes for subserosal deposits, but mind you that a far distant primary tumor can produce such seeding tumors here. For example, like bronchogenic carcinoma, it can result in seedling tumors in the small intestine and colon, and also the breast can do so, the bronchogenic and the breast, and then something intra-abdominal like gastric, pancreatic, ovarian, all can result in subserosal deposits. Here we have again another one, subserosal deposits resulting in diffuse narrowing with irregularity, but here there are the masses. The subserosal deposits are seen as masses, and here at the same appearance. These are seedling from pancreatic tumor. Ovarian masses can result in such an appearances also. Seedling tumors, subserosal seedling. It appears as small irregular indentations, displacement of the lumen. These all are ovarian. So this one is ovarian, and the other we have this one, which can be due, as we said, gastric, ovarian, and pancreatic. Gastric, ovarian, and pancreatic. This is pancreatic. Gastric, ovarian, and pancreatic, and this is ovarian. These are the three main abdominal tumors that can result in seedling: gastric, pancreatic, and ovarian. And we can add two far away tumors, the breast and the bronchogenic carcinoma. So collectively, breast bronchogenic carcinoma can produce seedling metastasis in the small intestine, and we have the three important: gastric, pancreatic, and ovarian tumors can result in such an appearance, such seedling. Perihepatic mets due to ovarian carcinoma. This also has differential diagnosis, is the which is the subcapsular hematoma and and irradiation changes. Irradiation can result in such change. Hematoma can appear, but usually without nodulations. Nodulations means deposits. So nodulations, these are nodulations. Perihepatic nodulations are due to ovarian carcinoma, and we can also include the other 5 things we just mentioned: the breast, the bronchogenic, the pancreas, and the gastric, plus ovarian. These are the 5 main tumors that can result in seedling and subhepatic nodulations. Let us see this one. We have here nodules along the falciform ligament with calcification, and here nodules are seen definitely. These are ovarian carcinoma metastasizing in falciform. If deposits are widespread like this, indenting the liver, causing masses, indenting the left lobe here, surround the stomach in this area. This is not clear peritoneum. This is peritoneum loaded with metastatic deposits, and this is called pseudomyxoma peritonei. We have another differential for pseudomyxoma peritonei, that is what we call peritoneal mesothelioma. Peritoneal and mesenteric mesothelioma. It will result in soft tissue masses widely scattered and continuous and confluent with each other within the abdomen. This is the second possibility. The third possibility will be the lymphoma. So we have 3 conditions which can result in diffuse filling of the abdomen with masses, soft tissue masses: pseudomyxoma peritonei of deposits, lymphoma, and mesothelioma of the peritoneum. Again, we'll see the 3. This is pseudomyxoma peritonei, masses filling the peritoneum. This is mesothelioma, masses filling the peritoneum, confluent with each other. And this one is lymphoma, masses filling the peritoneum and confluent with each other. 3 conditions can produce such an appearance. Again, mets can result in indentations of the stomach like that, subserosal deposits, and usually the main is the melanoma. The most common is the melanoma, but others can do. And we have seen small intestinal loops invaded, irregular mucosa invaded, submucosal deposits, subserosal deposits, and the infiltration in between. Of course, we give the differential, which is the gastric carcinoma, the pancreatic carcinoma, and we have seen ovarian carcinoma and faraway tumors, breast carcinoma, and bronchogenic carcinoma. Please, you put in this list also melanoma. So melanoma is one of the causes of such deposits. So to recapitulate and collect the differential diagnosis of subserosal deposits in the colon and in the small intestine, it is either from the abdomen itself in gastric, pancreatic, and ovarian carcinoma, from distant areas like bronchogenic and breast, and finally we must put in the differential melanoma. Melanoma deposits can produce such horrible things. CT for cancer esophagus can show that the tumor is filling the lumen, so it's the lumen. Once it is interrupted, that means we have passed stage 1. The infiltration of the wall, that means that we reached stage 2, and going out, causing some irregularity of the outline, as in here and there. This means that stage 3. But if we compress or eat up a bronchus, this is called stage 4. So once we see an esophageal carcinoma, it is either stage 3 or stage 4, because once you see it, it means that it comes out of the mucosa and it infiltrates the wall. Infiltrating of the mucosa is stage 1, wall is stage 2, irregularity outline is stage 3, invasion of a bronchus is stage 4. Bronchus or nearby structures. Gastric mucosa is interrupted with large filling defect. Of course, gastric carcinoma can be due to cauliflower mass, could be due to annular growth, and could be due to a creeping tumor along the outline called the linitis plastica. And here in this one, we can see the extension along the outline, intraluminal and along the outline, causing reduction of the lumen of the stomach. These are examples of gastric carcinoma. This is the inverted 3 sign appearance, and this is the inverted 3 sign appearance of the duodenum, which is indicative of invading carcinoma. Usually pancreatic carcinoma will do such an appearance. Extramural spread. Any cancer can produce extramural spread. In such case, we have luminal irregularity and soft tissue mass around, but we should differentiate between such an appearance and the appearance of GIST. GIST and sarcomas are usually have endophytic component and exophytic component, but they are not usually surrounding the lumen as in this case. Here we have the bilateral, on both sides there is a mass. In sarcomas are usually invading from one side, and it's mainly outside the lumen, and the part inside the lumen is small, but here the part inside the lumen is almost extensive like the part outside the lumen. So this is carcinoma invading with extramural spread. This is T1 with contrast, and there is large perinephric blood collection. It is post-biopsy blood collection. Now coming to this one, these are nodules similar to the nodules seen in the perihepatic cases of deposits. So we can have perirenal deposits appearing as nodules, and such an appearance could be due to lymphoma, of course. This is nodules of lymphoma. So we have nodules of deposits and we have nodules of lymphoma, or both are similar to each other. Now this one is a case of definitely retroperitoneal lymphoma engulfing the aorta and IVC with extraperitoneal surrounding lymphedema and stranding. These are the stranding in the extraperitoneum, Gerota fascia and the extraperitoneal, but this is the retroperitoneal lymphoma, large, and as we said, it is encasing vessels. These are typical perirenal lymphoma deposits. So this is an appearance, and this is the other appearance, perirenal lymphoma, and this is the third one, just layer of encasement, lymphoma of the kidney. So we have 3 or 4 appearances now. 1, 2, 3. All are due to perirenal lymphoma. The fourth one will be astonishing. This is the fourth one, which form a large mass encasing the kidney. So now we have 4 types of perirenal lymphoma. Lymphoma as a nodule, lymphoma as multiple nodules, lymphoma as one layer bilateral, lymphoma as one mass encasing the kidney. But the similar thing is the hematoma also. Subcapsular hematoma is usually confined to the capsule, forming or confined to the shape of the kidney. This is subcapsular hematoma. Here we have an aortic aneurysm which is leaking and extending to anterior pararenal space. Aortic aneurysm, abdominal aortic aneurysm with leakage extending into the anterior pararenal space. This is a graft, and there is definitely air around, so there is also extension into the posterior pararenal space, because we have here an infected aortic graft and there is extension of the infection posteriorly. Mind you that this type of laceration is a dangerous laceration, because it might not be confined to the liver, but it may indulge any of the hepatic veins posteriorly, while going to the inferior vena cava, and thus if you suspect a laceration at this area, at the right lobe medially, with minimal fluid like that, instruct the surgeon that while operating, take care that venous leakage can occur, because once they remove the liver, they displace the liver to work here in this area or to discover and see what is there. The blood will gush out and the patient may succumb on the table. Here is are examples of appendicitis with extraperitoneal air, and the air is seen around the or at the posterior pararenal space, extraperitoneal. Rare but can occur. Here another one, an extraperitoneal appendicitis with large abscess formation. This is typical for a psoas abscess with air formation, and these are the iliopsoas abscesses with extension. One is seen extending down. So iliopsoas abscess with air formation can occur. Pancreatitis can result in many changes, including sentinel lobe formation, which is called stasis, gas distended colon, it's a sentinel lobe also. So sentinel lobe is a lobe pointing to the region of an insult. Sentinel lobe is a stasis, is hypotonia of part of the small intestine or the colon, denoting that there is something wrong here. This is the word sentinel lobe, just a pointer. Here there is stasis due to pancreatitis. So acute pancreatitis, the first sign is the presence of sentinel lobe. Sentinel lobe can be dilated duodenum, can be dilated distended colon, and can be obstructed duodenum with dilatation. These are all pointing to that a lesion is nearby here, that the pancreas is involved in an inflammatory process. Here the pancreas is incomplete. The region of the head is hazy, surrounded with fluid, and it is extending into the anterior pararenal space in this region. So this is necrotizing pancreatitis, and here are the multiple fluid collections. So this represents necrotic material extending and filling the anterior pararenal space. So these two examples are examples of necrotizing pancreatitis. If you find some air here, you will add emphysematous, necrotizing emphysematous pancreatitis. And if you have this pancreas swollen and large like that with decreased density, you will add here edematous, necrotizing emphysematous pancreatitis. So it is just a description to the condition you have. Of course, here the fluid seeping around will result in after inoculations and the well-known pseudocyst formation. In such cases, we have to take care about the portal veins and inferior vena cava, because sometimes thrombosis in such structures can take place. Here, the chronicity with loculation and pancreatic pseudocyst formation. This one, the pseudocyst as related to the tail of the pancreas, which is atrophic, calcific, with dilated pancreatic duct inside. This is the dilated pancreatic duct, and these are the calcifications inside the pancreas, and the pancreas as a whole is atrophic, but it is related to a large cyst, and this cyst is seen connected with the capsule, so it results in indentation of the parenchyma, renal parenchyma, because it becomes a pseudocyst of the subcapsular region. Pancreatitis can result in, as we said, in thrombosis and the ischemic insult, and the end will be an ischemic mucosal atrophy. Pancreatic pseudocyst can push the stomach if it is related to the lesser sac, can push the colon outward if it is in this area, can push the stomach and transverse colon up if it is in the middle of the abdomen. So it depends on the site of the pancreatic pseudocyst. Pseudocyst can reach large size, as in this MRI. We have two big pseudocysts anterior to the kidney and region of pancreas. The presence of more than 3 loops in the abdomen, and these 3 loops showing caliber more than 3 centimeter or multiple fluid levels more than 3, it means that there is small intestinal obstruction. So 3 loops with dilatation, or 3 loops with fluid levels, or 3 loops with more than 3 centimeter are all pointers to a small intestinal obstruction. It's nice to see this CT for Crohn's disease, in which we can have the congested vessels, hyperemic periedematous tissue appearing as black around the vessels. This is very vascular edema, and you expect this very vascular edema due to inflammatory process going on. And lymphosarcoma of the small intestine, usually there is displacement by large sized lymph nodes in between. But if we study the loops itself, there are some changes in the mucosa, but the main changes here are the large lymphosarcoma here is manifesting with large sizable retroperitoneal lymph nodes bulging in between loops. In ischemic enteritis, expect to have a long segment of narrowing with some printing. Long segment of narrowing with subprinting. Of course, this is similar or closely similar to the subserosal deposits, but it is a history which can yield the diagnosis. So we have at least 3 relapsing mesenteritis, ischemic enteritis, and subserosal deposits, and sometimes graft response can result in such an appearance of the small intestine. So mesenteric hemorrhage, mesenteric ischemia, subserosal deposits are all indentations from outside or from the submucosa. This one is showing air outside a narrow lumen. There is a narrow lumen here, and this narrow lumen showing serrations, and this air is filling some of these serrations. This is the typical sawtoothing in spasm of the sigmoid, while the cause is diverticular disease with pericolonic edema and inflammatory reaction. These are the necks of the diverticuli. Some are filled with contrast and some are filled with air. Diverticuli filled with air in spastic sigmoid, and here the periphery is showing air. That means there is portal venous gas is reaching into the liver. If you find the following findings, we should consider the paraduodenal hernia or the internal hernia. First is that you will find some lobes are conglomerated together, and second, they are fixed in position, and third, they are preceded with or followed by some dilatation. And if you are able to find an area where there is change of caliber, you will be happy. These are the internal hernias. This part are confluent lobes are seen, and here they are dilated, and there is definite change of caliber in this area. So there is definite change of caliber, and here also there is definite change of caliber. It could be on the right, they call it right paraduodenal hernia. It could be on the left, and they call it left paraduodenal hernia. But expect it if you find it conglomerate together, focal loop dilatation, change of caliber, and fixed in position. This is internal hernia. And this is internal hernia. This cecum is seen through the foramen of Winslow behind the stomach, and this is called internal hernia. Cystic peritoneal masses could be mucinous carcinomatosis, could be abscess, could be pseudocysts. Uncommon is pseudomyxoma peritonei, mesenteric cyst, TB, and mesenteric cyst, of course, has another synonym, is called lymphangioma, and rarely we can find inclusion cysts or hydatid. Solid peritoneal masses commonly are deposits or lymph nodes. Deposits or lymph nodes. We might include also the mesotheliomas, carcinoid, and the sclerosing mesenteritis, and rarely GIST. Peritoneal carcinomatosis, of course, is the most common. Lymphoma is the second. Carcinoid and other lesions like desmoid and mesothelioma. This is the most common primary peritoneal malignancies: mesothelioma, peritoneal serous carcinoma, and desmoplastic small round cell tumors of the peritoneum. Thank you.